we should be concerned about cardiovascular health, because if we put you in a pool of 1 million people, it is the thing that is most likely to cause your mortality.
The United States, CVD kills someone every 33 seconds, so it's something that tremendously affects all of us.
Everybody's worried about their cholesterol too in relation to testosterone and what it may or may not do to their cholesterol. Why should we care about cholesterol? What is it?
We're born with cholesterol, and it starts to affect us from birth, and our behaviors and our lifestyle sort of dictate our risk as we age.
Part of the crux of being a clinician and practicing for years, you start to distance yourself a little bit with the research. What do we do, and what drugs are out there, what treatments are out there, and what non-traditional pharmacological treatments are out there?
Trying to cure the world one patient at a time of testosterone deficiency. Welcome back to another episode of the Vitality Code podcast, now powered by Vitality Telehealth Services for all your telehealth medical services and needs. I am one of your esteemed co-hosts, Dr. Jason Farrah, along with my panel of esteemed colleagues.
Yeah, I want to be esteemed.
Yeah, highly lettered.
Highly lettered.
Well, what's
lowly lettered?
What's the thing, Step Brothers? We're a learned house of doctors here. Many leather-bound books. Yeah, we're back. We're back, guys. Episode 32. Dr. Jeffrey Farrah, my well-bearded colleague and brother. How you doing,
Coming
my friend?
back. I'm doing great, man. I'm doing great.
And we have a special treat today. We brought on the new Chief Operating Officer of Vitality Telehealth and CEO of Physique U, Dr. Chester Sokolowski. How you doing, Chester?
I am fabulous. Thanks for having me.
Nice to see you. Coming in from Sarasota, beautiful Sarasota, Florida. Have you had a gator sighting in the last 24 hours?
Every day.
A pond in my backyard, and there's an alligator that is living in there. And he visits, especially when I meal prep. I'm going to grill up some steaks and some chicken later. And he always pops out.
Yeah,
you're gonna toss it to him. Don't be that old lady that feeds the alligator.
I know. He's like, dog, give me some of that. Can I get some of that steak? Yo. Yes. So, Chester, I heard a rumor about the bearded one. I heard that he switched up his workout regimen a little bit to include more cardiovascular fitness for the purposes of training for either a marathon or half marathon or something. I think your daughters, Jeff, were competing recently. Is that, or did I have this wrong? Did you do it half or a full marathon?
I did a half. Yeah, it's been a minute, but Stacy and my oldest did it with me, or I did it with them, I should say. I would not recommend it. It's terrible. Awful, terrible.
Because you didn't train, or because
of course I didn't train. I didn't train because it does suck to run. For me, I'm sure there's some runners out there that love it. It's just not for me. Every moment of training I despised.
Wow. So you're working on that anterior mid-singlet gyrus, working on hard things. You definitely
it was awful. It was horrible.
Yeah. It's just the nature of the beast, or.
It's just not running for me. It's just I don't need time on the trail. I don't need to get away from people and solace and think for miles and miles. It's good till about 6 miles. That was kind of fun. And then after that, I despised every bit of it.
Yeah.
My joints hurt. No runner's high here. My joints hurt. I got soft because I quit working out as much. I didn't particularly like it.
Oh, wow. Okay. Wow.
I'm not the one to sell. Of course, I didn't do the Boston Marathon like yourself. So
this isn't the segue that I hope that. Yeah, geez, man, talk about.
I hate to burst your bubble, but I did eat a half dozen donuts while I ran. That may not have done me well either.
I probably should have done that. I mean, when the old guy with the cane started passing me, that was a sign that I should have started
the best.
Eating the donuts. I couldn't believe that. Remember when I fell off the map? I was so slow.
They closed the race down. They closed the race down. You got time capped on a 8-hour marathon or something. I don't know what it was.
Oh my God.
They're like, Boston has to get back to life, Jason. You have to get off the streets.
The city needs to get back to resume regular activities here. You're shutting down the financial district.
Paul Revere is calling.
The British are coming. Jeez. Oh my gosh. Yeah, that was rough. Hey, but it was for a good cause, and I raised money for charity. And so, That's what.
AKA you bought your spot into the Boston Marathon.
Yeah, exactly. Otherwise known as. All right. Well, it's good to see some things never change. So speaking of that, I know that we're all involved together as a telehealth team, and we're seeing a lot of different disease entities, along with trying to cure the world one patient at a time of testosterone deficiency. So hopefully make it a better place for everybody. In all seriousness, no, we are doing those things and much more. But what I see a lot in clinic, what I've seen recently, lately, and even in the telehealth arena is, especially as a surgeon, coming into more of a primary care type focused role in treating disease prevention, optimizing wellness, and things like that. I'm seeing a lot more in the front lines of things that I already knew from general medical education and being, juxtaposed to these other specialties for so long, but I'm seeing it more in my face. And one of the things that I've been noticing lately is hypertension and as well as cholesterol. And it's been a hot minute since I learned about Rosuvastatin, or HMG Rosuvastatin, or back then it was Lipitor, and HMG CoA reductase inhibitors. And I know that it's kind of a hot button issue. Everybody's worried about their cholesterol, and everybody's worried about their cholesterol too in relation to testosterone and what it may or may not do to their cholesterol. And that's one of the big questions I get with TRT, both for men and women. What about you? What say you? What do you think of the current landscape of, it ties into cardiovascular disease, which, by the way, is the number one killer worldwide, the number one cause for mortality, and is expected to continue to rise at least over the next 15 years or so, if not longer. Do you see that bearing out in your clinic population, and what kind of things arise for you, Jeff?
Sure. I think my first introduction to cholesterol and cardiovascular health is people's concern with testosterone and how it's going to affect their cholesterol. Right. When I was relying on the research and relying on my education to tell me what would happen in practice without having a patient base to rely on, I was under the understanding that this was something I needed to be acutely aware of. Testosterone replacement was going to significantly negatively impact people's cholesterol. I can't say I've seen that come to fruition. And I know we have some research on that, and I think it can affect it for some people. And it is something that should be of concern, just because, like you mentioned, it is still the number one cause. When I talk to patients, I kind of put things in risk stratification and say, like, we should be concerned about cardiovascular health, because if we put you in a pool of 1 million people, it is the thing that is most likely to cause your mortality. So it is important, and cholesterol does play a role in the management of that risk for cardiovascular disease. Like you said, it's the number one. Is it worldwide? I know it's in the U.S. It's the number
absolutely
one.
Worldwide. Yep.
Yeah, which
Leading
makes
cause
sense.
Of death. Yeah, worldwide. Yeah, American Heart Association estimates that 1 in 3 people will be affected by cardiovascular disease in their lifetime, with the most common clinical manifestations being coronary artery disease and ischemic stroke. And I think, you bring up a good point too about this, is the conflation in the literature historically, and the conflation in society at large, as well as the personal database each and every physician practitioner, researcher, anybody that has, we have our own personal bias and database that we come with, and along with our experiences. But I have not seen that bear out in testosterone therapy. In fact, especially with bioidentical hormone therapy, as well as traditional TRT, if done correctly and at optimized levels, you see a reduction in cholesterol, typically, is what I see. Now, that's speaking empirically from my own clinic and the labs that I'm getting. And so that's a small subset of patients, and I'm not saying this is a randomized control study.
Yeah, but I think it's an important subset of patients, right? It is an important factor in our decision making. I think a lot of times as physicians, sometimes clinicians versus researchers, the researchers always appear to have the correct answer, and I don't know that that's always true. I think it's taking both of those pieces, researchers and the clinicians. Right. What are you seeing? And
And so I'm giving deference to that too, because there's also going to be a bias with your empiric data too. But it is important. You're right. But interestingly, I've had people come into any TRT clinic. You're going to see this. People that have been on steroids, anabolic, androgenic steroids. I've had people over the years. One of the worst offenders I remember is Winstrol, Trenbolone, these androgenic compounds, and the HDLs just drop. So clearly, those compounds are having a massive effect on testosterone and also what's going on in the liver in terms of synthesis or vice versa. And then I always think of testosterone. It's not an androgenic, and it's not it is androgenic, it is anabolic, but I don't link it in the same classification as other AAS because it's found endogenously in the body. But in my mind, I'm not saying this is a hard and fast rule, but you can make it into something that's bad with super physiologic doses. And then there is literature to back up that at those doses, you might see negative testosterone.
Reductions in your HDL.
Sorry, yeah, exactly.
This is the specific one. That's our good cholesterol, right? That's gonna
exactly right. And then that's the whole thing that's the good cholesterol. LDL is the bad cholesterol. But it turns out and then there's triglycerides and there's the Friedewald equation. And how do we figure out yada yada? So I guess that takes us back to the groundwork. And there's a lot going around too in social media, the podcast universe, basic conversation as people become more and more enlightened, and the internet generation and everybody's social media connectedness, that I kind of wanted to bring it back to basics and say, okay, let's just start from the fundamentals. What is cholesterol? Why should we be worried about it? Let's kind of delve into this a little bit deeper to set the groundwork for people that may be interested. Okay, you're always talking about my cholesterol, and I hear you, and it needs to be this number, but is it a big deal? Is it not a big deal? When should I worry about it? I heard, my buddy got on statins, and his muscles are all sore, and his liver enzymes went up, and he had to get off. And you doctors, you just push these medicines that you don't care about. Blah, blah. So let's start at the beginning. Chester, bring your science background, in your research background in here a little bit. Why should we care about cholesterol? What is it?
Okay, so let's start with why should we care? As you guys mentioned, it's kind of linked with CVD, sort of more cholesterol, negative measures of cholesterol, sort of those negative measures of LDL could be linked to CVD, cardiovascular disease, which is the leading cause of death worldwide. Globally, it takes out 30% of people. So globally, 30% of deaths are CVD related. In the United States, CVD kills someone every 33 seconds. So it's something that tremendously affects all of us worldwide, especially in the United States. And essentially, this is a disease cardiovascular disease, atherosclerosis, cholesterol. We're born with cholesterol, and it sort of gradually increases upon birth. So you're saying that so it's obvious that we should care about cardiovascular disease because it's the number one taker of life, if you will. It's the number one taker of life, and it affects all of us, and it starts to affect us from birth, and our behaviors and our lifestyle sort of dictate our risk as we age, but that those behaviors and that lifestyle start from essentially when you come on this earth. Atherosclerosis is a progressive disease over time, and it essentially starts at day one.
So atherosclerosis, just for the audience at home, I think a lot of people, it depends where you are in your education level and what your interests are, but is that the so-called hardening of the arteries? Is that, is that what you're talking about? And can you tell us a little bit more about what's going on there?
Yeah, let me jump back real quick. So let me just define cholesterol. So it is a lipophilic molecule that is essential for human life. Now, in English, what that means, it's a molecule that's going to dissolve in fat, and this sort of helps it sort of travel in blood, as well as gives it some of the physiological properties as it has, because it's responsible. It's essential for life. So every single cell you have has a membrane, and cholesterol is embedded in that membrane, and it helps give the membrane fluidity. So you think of a cell, sort of this 2D model, you probably see it, on a piece of paper or something like that. Well, in reality, a cell is 3D. It's fluid. It has no movement to it. Objects are traveling in and out, and cholesterol enables sort of the structure of that cell to remain intact, as well as permit some of the functionality with those transporters. And
so we need cholesterol. It's not that we don't want.
Yeah.
Okay.
It's the building block to bile acid, which helps you digest your fat and your fat-soluble vitamins, A, D, E, and K. It is essential for the synthesis of vitamin D. We need that to survive. It's the building blocks of your steroid hormones, your cortisol, your aldosterone, your adrenal androgens, as well as your sex hormones, your testosterone, your estrogen, and your progesterone. So you cannot live without cholesterol. Your cells cannot survive. You could not make the necessary hormones you need to survive. So cholesterol is absolutely essential. And I don't like to think of it as kind of, we oversimplify it as good and bad cholesterol and HDL and LDL. But in reality, if we look at the actual molecules of cholesterol and the HDL and the LDL, they're all the same cholesterol components, but we have to oversimplify them so the public can understand them. So let's just kind of jump back.
But we do say that I agree with what you're saying, but I also think it's a little bit more nuanced insofar as of the molecules, and you could just roughly say HDL, and then you can, on the other camp or on the other side, you can say non-HDL, one would be predicted to be more worrisome or predisposed to deposit into the wall of the artery in the intima and cause disease, and one would be less predisposed. Isn't that correct?
That is correct. So cholesterol, due to its lipophilic nature, is going to sort of travel in blood with these clumps of fat. These are lipoproteins, these clumps of fat, and they have different compositions, if you will. They have different amounts of protein and fat within these balls of fat that the cholesterol travels in. So you have these different lipoproteins, and you've probably heard of them. We have very low density lipoprotein, which is, as it kind of sounds, it's lower density, so it's lower in protein, higher in fat. A VLDL, as we call it, it's about 8% protein, 18% cholesterol, 18% phospholipids, and 52% triglycerides. So we're looking at a relatively larger ball of fat as the VLDL. And then some of those fatty acids, those triglycerides, they get broken off, they get cleaved off, and then you get an LDL. And it's a little bit more dense, but still relatively not as dense. It's a low density lipoprotein, LDL, the bad guy, the bad cholesterol. It's about 20% protein, 47% cholesterol, 23% phospholipid, and 9% triglycerides.
And then it's just a continuum as you go.
Yeah, it's a continuum, if you will.
More protein, less fat when you go up towards HDL, right?
Correct. And LDL is the guy that can kind of travel inside, especially the smaller, more dense LDL. It can kind of break through some of these barriers in your endothelial cells in your arteries, and then it can potentially go into the intima, sort of that underneath space in those arteries, and then sort of build those fatty streaks, if you will, those deposits of fat, and then they gradually build up in fat over time. They accumulate more lipid, and what that can cause is the atherosclerosis, sort of the narrowing of those arteries, the reduction of blood flow, and potentially those deleterious side effects. In terms of, all the CVD, the ischemia, all those different kind of negative things that could eventually negatively impact your life and ultimately potentially kill you if they get too bad.
So you're saying that this cholesterol, just to summarize, it deposits into the wall of the artery, into the endothelium, recruiting smooth muscle cells and macrophages, builds up the thickness of the artery. These foam cells where macrophages engulf the fat, and then that gets deposited, injures the vessel further. But it all starts out with something that activates the endothelium and recruits these guys to these sites to be deposited in the first place. So it's the combination of the cholesterol present, specifically the types of cholesterol that are lower in density, that tend to be more oxidative and more damaging, or to be able to be oxidated and thus activate endothelium more than do the high density, which tend to take cholesterol back to the liver, where it gets recycled and excreted in the feces. The other stuff stays around in the bloodstream, tends to be deposited in the lining of the artery, the endothelium, and then the subendothelium underneath there, under such conditions as are favorable to do so, and those are intimal injury, so inside injury to the from shear stress of high, non-laminar blood flow from high blood pressure, and then other types of injury from oxidative stress. So it's both things together, right? In this kind of that chicken and egg concept. I know I skipped ahead a little bit probably in the progression there, but does that sound right?
Yeah, that's 100% correct. So in order for the clumps of fat, the lipoproteins, in order for them to sort of get into the artery where they can essentially cause chaos, they have to sort of break through a barrier. So we have these cells that are going to protect the artery called these endothelial cells. And if they're damaged or if they're compromised in any way, their structure, their function, then these LDLs can break through the barrier and then go into the sort of intima of your artery, sort of that inner middle portion of your artery. And then they have the potential to be oxidized, which means lose an electron. And then they can become unstable. And the body responds by recruiting different cells, in particular monocytes, which turn into macrophages, which can then eat up that oxidize those damaged LDLs. And then essentially the macrophage is going to then form a foam cell, and the foam cell can deposit, it can localize within those arteries, and the cascade continues. More and more fat can kind of drip through those holes in the compromised endothelium, and then more fat can be added, and the plaque can form. And plaque is just essentially fat with a little bit of calcium, with some fibrin. So it's more than just fat, but essentially you have this fatty streak, this plaque, and it just continues to grow and build until there's some really serious problems, potentially restricting blood flow. But yeah,
restricting blood flow, and then restricting blood flow leads to more non-laminar blood flow, basically putting your finger over the end of the hose and how it sprays out in all different directions and at a high rate of, higher velocity. And then that creates more injury, and it's a vicious cycle. These plaques become necrotic and fragile, and they're injured, damaged goods, and they are not healthy. They continue inflammation. Inflammation that's persistent begets cellular death. Cellular death turns into necrosis. Necrosis leads to cracking, basically, and damaged tissue. When the body has a damaged inner lining of its blood vessel, that sets off a clotting cascade, which is what you do when you cut your fingers. That's a response to trauma. And when those areas of narrowed artery or diseased artery crack, there can be an acute thrombosis, a clot there, and then that gets interruption of blood flow, such as what is, like in a heart attack, that kind of thing. Just to kind of add on a little bit more downstream. So when we're looking at that, when you get a typical panel, you're looking at biomarkers, you're looking at the higher density, the low density, you're looking at triglycerides. Is that all there is? And is that all we should be looking at? And is that the end of the story?
The LDL and the HDL are sort of the classic, most common markers when people think about disease risk. And there's fabulous data that says the higher your LDL is, the greater the risk is for cardiovascular disease. And similarly, the higher your HDL is, the lower your risk is for cardiovascular disease. So those are two sort of classical markers that people look for. But we've sort of gathered some new data, and now we have this new marker called apolipoprotein B. So let's remember these lipoproteins, the LDL and the HDL, they're a combination of proteins and fats that travel in the blood. And the apolipoproteins are essentially kind of little markers that assist in both the structure and the function of these lipoproteins. And a particular apolipoprotein, this apolipoprotein B, is associated not just with LDL, which is obviously can promote atherosclerosis, but also another lipoprotein called lipoprotein A. It's Lp(a), and not many people know about that. But it's a similar lipoprotein to LDL, and it can sort of contribute to this atherosclerosis. It can contribute to this buildup of fat and potentially have those deleterious effects. So you have your apolipoprotein B, ApoB, and it's a reflection of both your LDL and your Lp(a). So ApoB is typically, it's becoming sort of the new marker in terms of what to look for and the biggest and best predictor of potentially adverse effects. So your LDL is more the classic measure, but your ApoB encompasses your LDL, but also your Lp(a), and LDL and Lp(a) are kind of the two molecules that sort of contribute most to your atherosclerotic progression.
The interesting thing that I saw in the research in leading up to this episode was that so you on a standard panel in our clinic, and it's not standard this wherever, but I don't know about you, Jeff. I get a LDL, HDL, triglycerides, cholesterol to HDL ratio, which is just calculated. I don't currently do VLDL. I don't currently do IDLs, intermediate density, or LPAs. And I don't currently, but I think I'm going to now listen to Chester, maybe start looking at ApoB or ApoB. What do you do in your clinic?
Yeah, I think you're right. So I've been starting to do, while you guys were talking, I was actually looking up my labs from 2022. I think was actually the last time I ran my cholesterol panel.
Your personal one.
My personal one, yeah. And we have very different familial histories. I've always said I think you got dad's genetics and I got mom's genetics in terms of cholesterol. But yeah, I've started to I run the same panel that you do. So I run the triglycerides, the cholesterol total, the HDL, the LDL, the ratio, but I also include a CRP with all my lipid panels. And then more recently, I've been including ApoB as sort of an exercise in this new maybe greater, as a nod to greater specificity for predictability. As you know, I'm trying to just build a case for a certain subset of patients who are more interested in, and I think we have an explosion of scientific information right now. And so, trying to further refine that predictability for patients who may be concerned or may not be concerned about their cardiovascular risk. And so trying to lay that case out a little bit more well-defined for them.
One thing that, I agree, and I'm going to start doing that too. Here's why. Here's a couple reasons why. So first off, I think what you're trying to do now, you can use it as a treatment target, meaning you can look at the LDL and say, I want it less than 100. And then if I do that, what does the randomized controlled data show me about people who have never had a heart attack, recurrent heart attacks? How can what risk reduction can I get, right? If I do that. And then you have to balance that against the risk or side effects of the medication, that kind of thing. Okay, so that would be the benefit versus the side. Okay, so let me ask you a question: if LDL was the sine qua non, or if it was like the panacea, and that was the best modifiable biomarker, etc. Would you not think that normal or lower cholesterol levels, especially LDL, would lead to or would be associated with better outcomes in coronary disease and otherwise? You would, wouldn't you? So Jeff, how many patients with recurrent acute coronary syndrome or coronary syndrome MI or troponin leak from obstructed coronary artery because of coronary disease ramifications or downstream consequences, how many of those people have normal cholesterol LDL levels recurrent?
I don't know the answer. I'm going to guess 50%.
Yeah, you're absolutely right. 50%. So wait a second. So 50% of these people that are having another episode of coronary syndrome have normal LDLs. Okay, there's something else going on here. To me, Chester, and correct me if I'm wrong, what I saw and you've laying this out is that there are atherogenic particles other than just LDL that aren't routinely measured, but could, I suppose, like I've seen VLDLs and I don't know about IDLs. So of the atherogenic particles, I'm thinking everything non-HDL. So I'm thinking specifically VLDL, IDL, and LDL. Okay. So if you had a marker that could show you all those rather than getting separate levels of that, and which have mathematical coupling. If you're doing, like Friedewald equations, things like that, there could be room for error that gets then propagated down the stream. It'd be great to have just one biomarker that unified all of those, one ring to rule them all, right? That's the cool thing about ApoB is that, correct me if I'm wrong, there's one ApoB 100 molecule, ApoB 100 specifically on those per VLDL, IDL, and LDL, meaning all the atherogenic particles, or at least most of them. I mean, you have the chylomicron remnants and things like that. But so if you measure that, you're by default measuring all those. And then if that's true, you should see that it should bear out to be a better predictor of disease and disease progression than you do with LDL, and that's what the Inner Heart study showed. It was a prospective trial that showed that it was a better indicator, ApoB, of first-time MI. So am I right to say that there's one ApoB molecule per atherogenic lipoprotein molecule? Does that sound right?
Yeah, and then I would add to that, you got to consider the Lp(a), and that's something that's, again, kind of nuanced and not many people factor in. The LDL cholesterol, and the Lp(a), the lipoprotein A, those are the two biggest, essentially, I would call them bugaboos, that are going to determine your CVD risk. So it's not necessarily your VLDL or your IDL, but your LDL and your Lp(a), and then the ApoB is going to be reflective of those two markers. In particular, the Lp(a), not many people get that in terms of tested, and it's highly, highly genetic. I got sort of the short end of the genetic stick, and my Lp(a) is absolutely through the roof. It was like,
but there's one ApoB 100 per LPA as well. So I should have mentioned that. There's LDL, IDL, VDL, and LPA. Each have exactly one molecule of ApoB 100. So when you measure ApoB 100, you're measuring all.
You're measuring all, though. Correct.
Yeah, ApoB is extremely, extremely effective. But I would also encourage people to not just get their ApoB, but also get their Lp(a), especially because it's one, genetic. Two, we don't necessarily have the best treatment for it. There's really no pharma options. There's really no lifestyle interventions. But if your Lp(a) is elevated, then I think it changes how you live in terms of what you're going to accept for risk and sort of your margin of error, if you will. Because, atherosclerosis, you kind of got to look at it not just as like one acute measurement. All right, let's take my LDL right here. Let's take my LDL and ApoB 6 months from now. Like, you got to look at it sort of area under the curve, if you will. How much essentially, I would say, like, potential atherosclerosis can you have based on how long your LDL is elevated, how long you sort of have this negative lipid panel that's not really conducive to promote health. You have to consider that over the lifespan. So start off when you're younger and then routinely get blood work every 6 months. And obviously, if you get your LPA and you think, wow, this is a genetic risk factor and I can't really do much about it, then your margin for error, that area under the curve that you have to have your other markers, that has to shrink. And then you probably have to have lower.
Yeah, but herein lies the crux of the argument, though. And I see what you're saying. How I would push back against that a little bit, and this is why. So if you say to me that half of all people that have recurrent MI or a coronary syndrome, okay, have normal LDLs, and if you also say that lowering your, and this is real data too, if you're lowering LDL to target from the 2018 AHA targets only get you a 30% risk reduction, then is it really that?
Furthermore, Jason, is that risk reduction relative or absolute? As I understand it, it's relative risk reduction.
Yeah,
it's a 30% relative risk reduction, which lowers the absolute risk reduction down to like 1%, 1.3.
Yeah, that's a really good point, actually. It is, and so, but here's my question. And so people conclude, look, either we're not measuring the right thing, and we need to measure ApoB because we're not getting all that, or my contention is. Look, there's two ends of the problem here.
You don't want to say it, do you?
Well, it's hard, right? Taking on big pharma and big science. Like, we found this target, and these fatty streaks and these foam cells and these plaques are comprised of cholesterol, but so isn't a lot of good things in our body. And in fact, you let off, and you were correct at the top of the hour here, that it was essential for life. And the very thing that's essential for life we're reducing. Well, I guess you can say, well, this can be too much of a good thing. Sure. But is it the chicken and egg? You have to get those in there for the most part, unless you're talking about genetic mutations and receptor clearance and things like that get the level so high they can precipitate or cause oxidation in themselves. You need some kind of inciting event. The endothelium needs to be activated to recruit the smooth muscle cells and macrophages. There has to be endothelial injury and inflammation, and the cycle that comes with the body's recognizing of inflammation, exuberant response, and then and so in the setting of that, and so you need other disease processes and other issues going on. And the question has always been in my mind: is cholesterol a problem? outside people with familial hypercholesterolemia extremes and things like that, and of course there's the relative risk reduction issue too. But is it that, or is it the inflammation and the endothelial injury? And if I concentrate on making my endothelium healthier and my risk of injury lower, is that better, equal to, or less than just lowering my some arbitrary target,
I think part of what I've always wondered is when you look at these risk reduction studies is we have the relative versus absolute, but we have the markers with which they are comparing the risk reduction to. So I'm going to go outside my knowledge base a little bit here, but I imagine like if we look at we look at a relative risk reduction of 30% from taking statins, is that risk reduction as compared to daily workouts? Is that risk reduction compared to eating a healthy diet? Is that risk reduction compared to eating a healthy diet and working out? Is that risk reduction compared to eating a healthy diet, controlling your blood pressure, working out daily, and stopping smoking? Would you get a better reduction from those things? And so when I look at, we've been talking about cholesterol and rightly so, because I think it does impact CVD risk, but is it the only thing, and is it the most important thing? Conversely, I think a lot of times my patients come in, they're like, I don't care. I'm doing cholesterol. My doctor keeps wanting me to do a statin. And that may not be the right answer either, but maybe we need to focus on some of those other things. And so I think the other risk factors can bear modification of the other risk factors for CVD can bear just as much fruit, if not potentially more fruit.
I agree. And so absolute risk reduction, meaning, so you have a 5% risk and now you're going to have a 50% reduction. So it's 2.5, or are you just going to reduce that 30% of the 5%? Like, is it,
correct, what I'm saying? Right. Yeah. If your relative risk reduction was 30%, but the total risk already was only, 2%, then you're getting 30% reduction of the 2%.
2%, right. Exactly.
Right. And so I think when I looked at that statin study, I was like, oh, so it's a 30% risk reduction. Like, that's huge. This is big. Maybe I've been wrong. And then I was like, oh, that's relative risk. And so if you look at the absolute risk, it was a percent. I think 1.3, 1.4 risk reduction from statin use. And so I tell patients that 1%, the way I explain it to them is that 1% may be huge for you. Like Chester said, you may have a genetic predisposition to this, so to speak. You may have a high LP(a). You may be really sky high in your LDL, your ApoB. You may smoke. You may have diabetes. You may not want to change those. And then I want that 30% relative reduction or that 1% absolute risk reduction. So I'm going to give you a statin because your risk is really high because you're doing these other lifestyle things. Now, conversely, if I flip that and you come in and your cholesterol's 220 and your LDL's 110, but you regularly exercise, you don't smoke, you don't have a strong family history as far as you know, you are eating well, you are exercising daily, you don't have diabetes, then maybe that 1% absolute risk reduction won't bear as much fruit, and then maybe it's a different conversation about whether or not you take a statin.
So this is, I love this, what you're saying right here, because I think this is a big part of dealing with this, moving from a basic science understanding to what's happening in real life. And that is always the thing that clinicians run into. They learn the basic science and hopefully evidence-based medicine in terms of studies, and then learn how to analyze studies, of course, have a framework of what they should do, but then that will always be challenged. Any plan for war goes out the window in the first, or what Mike Tyson say, when you get punched,
when you get punched in the face.
Game plan, yeah. So what you find in a patient in the clinic is much different, and what you can really, and you're describing that what you can really affect, what kind of change you can affect. So it sounds to me, Jeff, like you have a framework in your mind where you go through risk stratification to help you understand, does the person really need or would they benefit from a statin, or at least to help them understand if they want, here's what I can give you, here's the risk reduction I can give you, here's why it's important for you or may not be as important for you based on this list of things that you go through to help them kind of triage their risk, right?
Mm-hmm.
And
yeah, I think, and ultimately, like you said, it comes down to what I really fall back to. What do they want to do? Here's the data as I understand it. What would you like to do? The answer can always be yes or no. Like, I want to go on a statin. I'm really nervous. I'm really scared that my father, this, that, and the other. Whatever. I've heard this, and here's the risk, and I understand it. I want to do it. And so, but I like to put it into risk stratification for them. In this heart disease one, I start at the top, and I'm like, hey, what is your family history? Let's talk about, if we're talking about a male on testosterone, what are the lived experiences of the males in your family tree? You have grandfathers, uncles, your dad, your brothers. Are there MI events? Are there strokes? Are there elevated blood pressures? And honestly, I think, this was something I don't know if you experienced, Jason, but I was more prepared to have the cholesterol talk, and I was ready to get on the statin train and lower the cholesterol. And it was always a problem. We got to lower this cholesterol for heart disease. But my God, I find so many more guys with elevated blood pressures that either don't know or don't care than I see the cholesterol being a problem. I see a lot of guys with elevated blood pressure. And frankly, I think some of them, because it's maybe become so commonplace in their life, or it just seems like not a big problem, or they don't feel the problem, or it's not talked about as much. I don't know why, but they don't seem to care as much about that risk than they do the cholesterol or the physicians.
It's a silent killer, and they adapt over time, and there's changes that happen with aging. But yeah, I agree. I think it's a huge problem. So what? I think there's the American Heart Association has a couple risk calculators that, like, there's the ACVD risk factor, right? And
yeah, so there's one I keep on my phone so I can show patients, and the ACVD. It has a calculator built into the little app, and you can put all their information. I like to show them right then and there. And you can change the risk factors. Like, hey, what if we lowered your blood pressure? This is the risk reduction. Hey, what if we did this? And they can see right there in real terms. And, you can put their ethnicity in there. You can put their age in there. You can put their blood pressure controls in there. And so I like to show them that risk reduction right then and there in real life.
So one thing that I liked in looking at that, as a surgeon, I have never used that until getting into wellness practice. So it was new to me, but it's old hat probably to family practitioners and so on. But I would tell you, my family doc never did it with me, and I'm not saying that he should have or shouldn't have. But is at what point do you get on a statin? Because it almost feels like if I can, I can't. But if I as much as I can, taking off the physician hat and just becoming a guy walking around in society, it feels like, when I'm that guy, it feels like, oh my God, if my cholesterol's over 200 or my LDL's over, or any kind of perturbation at all, I've got to be on a statin. I've got to be on a statin. I've got to be on a statin. I don't have that same urgency. Again, outside my own education and knowledge of, to prevent heart disease, I got to lose weight. To prevent heart disease, I got to exercise more. I mean, you do, but it just seems, I don't know if it's a marketing thing. I don't know if it's I'm biased. Do you feel like that too, that people start to think that they've got to get their cholesterol down at all costs? And you don't know what I wouldn't know one thing I'd be interested in is, at what point should I consider the recommendation for a statin, and at what point should I not? Now, clearly you're doing that with your patients and talking about the risk stratification in your own framework. But the cool thing about this risk calculator is what they used, 5%. If your 10-year mortality or your 10-year event risk is 5% or greater, then they would use a statin. So let's do it. Let's do yours, Jeff. You're 40. What are you, 45?
46 this month.
46. We'll call you 46. Do you have diabetes?
I do not. I have pre.
Oh, I don't know. I don't know if we give you a yes or no. You're
not
male.
diabetic, but I'm pre.
Okay. You're not a smoker. What's your total cholesterol?
It was measured at 117, brother.
Oh my gosh!
Boom! That's solid. Wow.
It says very, very low. Double check.
It's almost a problem. I often wonder if my cholesterol is too low.
Gosh.
Yeah, that's for mom. I did nothing for that. I think her total was like 90 something. I saw it.
Jeez. What's your HDL?
40.
Oh, that's it?
Well, because my total's 100. Jeez.
Good, my goodness, yeah.
Okay, and what's your systolic blood pressure? Just generally run. Not today, but just
not after my Celsius.
Yeah.
I would say 128/78.
So I'm gonna put. You want to put 130 then?
Sure.
Okay, 130. So your 10 year according to this, your 10 year risk of a cardiovascular event is 1.3%.
Sweet.
So do you I don't think it's worth it to get 30% of that.
Of 1%.
Yeah, 1%. So
I think one of the interesting things too I saw when we talk about statins, I don't think a lot of docs go into this, is you can get, I think Peter T, I saw an article or a podcast from him, and like 85% of the statin benefit was reached at the lowest starting dose, which was, I thought was quite interesting, right? So higher prescriptions may be more likely, or I would consider more likely to cause the liver, the muscle, the insulin issues, but you can get 85% of that benefit from taking the lowest dose. Let's do your risk calculation, Jason. What's your total?
Okay, let's do mine. Mine was like just under 200, I think. Let me just put.
And you're not on a statin?
Nope.
Oh, I thought yours was higher. I've been lying about you all these years.
Well, I'm gonna get to that in a second. But my HDL
and my CTA scan was at 0. So.
Okay, now don't you throw in some extra variables. Okay, I'm gonna put my systolic blood treatment for.
What's your blood pressure? 135.
The other day it was like 160/100. I was like, "What?" In the clinic, I had a Celsius, a Magic Mind, a coffee. Like
What's
all
a
this
Magic Mind? What's that?
Oh, I love me some Magic Mind, man.
Oh, I gotta try it. What is that?
Oh my gosh! And I've been seeing
got some mushrooms in it. What is it?
Yeah, it's got the
some
nootropics. Yeah, some rhodiola.
It's got like a poof of that, and then a bunch more caffeine. They wave some mushrooms around in the factory, and then they dump a bunch of caffeine in there.
I think, Jeff, the correct term is nootropics.
Oh, sorry.
It's not. Yeah. Oh, my friend, diabetes, no, and I'm going to put myself on 47. Okay. Well, you know what? In July, I'll be 48, so maybe we should just put that up there just to see what that's like. No diabetes, male, sex, no smoker, 198 total cholesterol. This is interesting. Look at this. HDL, even though my HDL is better than yours, 45.
5 points.
My risk is 3.2%.
Change mine to diabetic. That's probably my biggest struggle is, I was on prednisone for so many years that I have this strong lean towards, I have to really watch my sugar intake. I just look at sugar and my A1C goes up. It's terrible, man. Of course, I did eat a pack of gummy bears.
Harlow, yeah. That's why, because you look at it and want it. That's why.
It just starts with looking at it. I actually do eat the whole pack.
Exactly. Harlow walks in with a Oreo cookie, and you're all of a sudden your sugar spikes. All right, so your HDL was 40. Let's see here. Let's see. All right, on air. Math is hard, apparently. And we're going to say you do have diabetes, right?
Yeah, if we change that.
So it doubled.
Yeah. And this is what I tell patients. 2.4. Yeah. So let's talk about the other things. If you don't want to get on a statin, I'm cool with that. Like that's your decision. I'm fine with that. You know the risk reduction, you know the relative absolute, you know where you fall. Like what's your family history? Are you leaning towards insulin resistance? Right. And I have found, we've talked about this on the show, but I have found some people that you would not expect. I put a glucose monitor on them. I'm like, how is your A1C 5.8? Do you look like, I got some people that I'm like, literally shredded abs, works out all the time. And I'm like, what's going on? Let's put a glucose monitor on you and see what you're eating. What is your blood pressure? Let's talk about those things. But to circle back, since the episode was more about the cholesterol, Chester, would you agree that if you could only measure one thing, would you choose the ApoB? If I put you in a corner?
Yeah, that would be, if I had to do one specific measurement. I think I've never had to do, only one specific measurement.
Right.
Yeah.
And I agree it's becoming to look like that, but that seems to be maybe the most likely one that we're leaving out. I think the total plays a role. I think the HDL, LDL, you're getting those in a lipid panel anyway. So why not measure the ApoB while you're getting your blood drawn and doing the cholesterol panel? I think this is part of the crux of being a clinician and practicing for years. is you start to distance yourself a little bit with the research. You tend to practice like you used to practice when you came out. When you come out of school, you're rich with knowledge and you're rich with the research, and you're very small in the practical management and patient information, right? And then the longer you practice, you get bigger and bigger and bigger in that practical information in your experience, but you're potentially distancing yourself from the research. So I found it very helpful in this exercise for this episode, was just having conversations with you, Chester, on the research side and how that brings us up to speed. It clarifies a lot of things too, and that's been a big plus for me. So I've started including ApoB measurements in a lot of my patients whenever I can, and whenever we're doing blood draws and it calls for it clinically.
I agree with Chester. It is clear in the literature that the LDL is not the biomarker that we need it to be and want it to be. And I, too, would pick ApoB because of the studies demonstrating superiority over LDL in terms of predictive power of recurrent events, first-time events, cardiovascular events of all kinds. And so, Chester, what Jeff's talking about and what I've been talking about, too, is risk factors in addition to cholesterol. What does modern medicine think are the top, 10 risk factors? I mean, what is it, just cholesterol, or are there some other ones? If you had to give me like a top 10, top 10 list.
Paper, and it ranked them. So number 1 was your cholesterol. Number 2 was your high blood pressure. Number 3 was smoking. Number 4 was insulin resistance. Number 5 was diabetes. Number 6 was overweight or obesity. And then we have, lack of physical activity, poor diet, old age, those type of things. And I would agree with you guys in your assessment, and that your endothelial dysfunction, chicken or the egg, what comes first to kind of trigger this negative cascade of health events? It's the endothelial dysfunction. But the issue is, and I put my little nerdy research cap on, I got the degrees in the background to prove that I did research. The issue is, it's just so simple to measure your cholesterol. You get a full lipid panel for $5.
Exactly.
How do you measure those lifestyle behaviors? How do you measure your endothelial damage or your oxidative stress? You can't put that I guess you can, but it's so challenging to put that in a paper. We'll get on another topic for a different day of, like how much it costs to do markers of oxidative stress to maybe get some indication of that endothelial damage, how much more expensive that is compared to a $5 lipid panel. And obviously, if you're going to have one of these mass studies with 5,000 people, you're not going to pay $200 to give them, all these, various markers of oxidative stress, but maybe, you'll pay $5 for them to get a full lipid panel. And then it's pretty easy to paint the LDL and the cholesterol, picture that is, the biggest negative determinant, when in fact, the endothelial damage, that could potentially be essentially the bigger sort of underlying risk factor that's kind of triggering this negative cascade. And also, Jeff, you said, is it easier to, I guess it's easier to go on a statin just to pop a pill than it is to exercise for 60 minutes a day.
Right.
A lot easier. We have some finances going on. We got some big pharma going on. And then we have like convenience for the person. Man, I don't have time to go to the gym, for 45 minutes a day or 40 minutes a day. Or I don't have time to eat clean or whatever it is, but they got time to pop a pill. So I think from a convenience standpoint and from a monetary standpoint and from how it is to collect these data, it's just much more simple to kind of just throw cholesterol as like, all right,
but LDL the bigger
guy, we're going to put that out and tackle it.
Yep, and that's super well said, and you're right on the money. And if you take it a step further, now I'll give you a little of my background with lipids is that even if you do the one thing that's easy, and it is a target, does it really do much? Half of people with normal LDLs have and on statins or whatever have normal LDLs at the time of recurrent CVD or ACS rather, and those people were put on statins afterwards. But in my own life, when I was at my worst health I would say my worst level of health in the last 10 years was probably at a peak at around 2.5 years ago.
While you are working in healthcare?
I was working in healthcare, working 21 days straight, literally, night and day cycles were all messed up, just ridiculous hours, surgery. I'm just ridiculous. Eating and drinking terribly. Even when I tried, so then I got my triglycerides were terrible. My LDL was high. My HDL was low. Got on statins, barely budged them. When I ceased to be doing all those things, began working out, doing kind of like a hybrid between kind of a HIIT therapy or a HIIT workout, high intensity interval training kind of thing.
Like a burn boot camp with your wife? Some bar class?
Yeah, doing the booty burn.
Okay,
thank you, Chester, for backing me up. I wasn't sure if Chester was going to pick that up.
I didn't want to say it, but you guys outed me. Okay, the booty burn, Brazilian booty burn. We were doing Roomba. But when I started eating healthier, dude, again, this with optimized testosterone as well. Now my HDL 45 and was as low as like 32. My LDL was close to 100, total under 200. Everything improved. I mean, it's unreal. When I could, and that's off statins too, by the way. I couldn't tolerate them. I had such.
So maybe a good thing to follow up on this might be if we could come back and talk about maybe some of the drugs, and then maybe even further coming back and talking about some of those lifestyle management issues would be good. Like I think we did a pretty good job defining what cholesterol is, but the other half of the equation is, and why it's important to measure, but what do we do, and what drugs are out there, and what treatments are out there, and what non-traditional pharmacological treatments are out there would be interesting to look at.
I agree. And when we do that, Chester, can you give us a little background too, maybe to start that off with, how testosterone impacts cholesterol and cardiovascular disease, and the role of potentially, just real briefly, androgenic anabolic steroids, even that which you can find on the black market, unfortunately, and that kind of thing. And because that ties into a lot of what we do too. And give us a little background on that, because I know you have some experience budding that world and knowing about that world. And we all do because of patients that we treat and that kind of thing. But yeah, let's talk about that next time. What do you think, guys?
Yeah, next time let's do it. Let's get a little testosterone talk, and then we'll jump into some other medications and lifestyle modifications.
Beautiful. Well, I appreciate you coming on the podcast as always, Chester.
Let's do our bicep off.
Yeah, I would lose that one. I don't know. I could maybe beat Jeff. Let's see that.
Well, you got the hoodie. That's why I wore the hoodie. It adds 10 pounds of muscle. Even though it's 100 degrees here in Tallahassee.
Oh, really? It's hot. Huh?
Well, it's not 100, but it's not hoodie weather.
What's the temp down there in Sarasota?
That's got to be toasty.
Yeah, I mean, it's warm. It's going to have a downpour at some point today. I was in the gym parking lot yesterday, and this C8 had a top down. And Florida summers, it just downpours, once a day randomly.
Absolutely.
It just started downpouring. This brand new C8 with his top down. Dude was in the gym, and our gym, you can't really hear anything, not a lot of windows. It just soaked this C8 for like 5 minutes. It was just a travesty. It's like watching your best friend get hit in the nuts. You just don't. It's painful.
Pain for both people watching and for him.
Right. Yeah, there's like multiple people in the parking lot. Like, oh, what do we do?
All right, guys. I appreciate it. We'll see you next time. Okay.
Sounds good, man.
All right. Thanks.